Hi, I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Abraham Bezuidenhout, an instructor in radiology at Beth Israel Deaconess Medical Center, and he'll be discussing with us his recently published AJR article on the association of unexplained acute distal pancreatitis with pancreatic cancer. Dr. Bezuidenhout, thanks so much for joining us.
Thank you very much for having me, Andy.
Okay, so to start off, please explain for us the current role of acute pancreatitis as a potential marker of pancreatic cancer.
Thank you for the question, Andy. At this stage, I think there's a limited role because such a small percentage of patients with pancreatic cancer presents with acute pancreatitis, I think, to the probably 2% of patients. So it's not that great utility to use at this stage.
Okay, so for this study, you actually had an observation in clinical practice that prompted you and your team to embark on this research. And what was that?
So it was like almost like an eureka moment, what I like to call it, at our multidisciplinary conference, where we noticed this atypical imaging manifestation of acute pancreatitis to where it was isolated to the pancreatic body and tail with sparing of the head. And this is very unique. We do not see it in our daily, or that often in our daily practice. And it's actually in our MDC that one of my pancreatologists pointed this out, and he said, this is a very abnormal imaging manifestation of pancreatitis, and we should look for the cause of this, as it's not just a run-of-the-mill acute pancreatitis.
So let's now turn to the study at hand. Can you explain for us who you were evaluating in terms of key inclusions and exclusions for forming your patient sample?
Yeah, so we wanted to look initially, in a small pilot type study at patients that presented with a first episode of acute pancreatitis. We excluded patients with known cancer, known subacute or chronic pancreatitis, or any interventions, as we basically wanted, initially just this clean sample to basically divide them into the two groups that we eventually looked at.
And what were some of the factors that could be possible explanations of pancreatitis that you searched for and excluded?
Yes, so as we've mentioned, we looked at this group of patients that had acute pancreatitis that was isolated to the body and the tail, or the distal pancreas, and spared the head. And so we wanted to upfront exclude potential causes that could cause obstruction of the pancreatic duct at the level of the body, and then would be an explanation for this atypical imaging manifestation of pancreatitis. So the patients that we excluded up front was, first of all, patients with a visible mass at the level of the pancreatic body. We excluded patients with a history of prior necrotizing pancreatitis, as we know that could cause duct injury or stricture at the level of the body or the watershed area of the pancreas. And also patients with chronic pancreatitis that could potentially have strictures or stones at the level of the body. And then lastly, we also know that patients with autoimmune pancreatitis could have segmental pancreatitis confined only to the distal pancreatitis. So we kind of wanted to, exclude those patients because we were looking, at patients that had unexplained acute distal pancreatitis, as you mentioned in the beginning.
So the next step, once you had your patients identified, was to classify them as having distal or non-distal pancreatitis. How did you do that, and what were the criteria?
Yeah, so we saw this, interesting imaging manifestation, as I mentioned, and so we basically decided that we are going to use the surgical term for a distal pancreas. The surgeons use the SMV basically as the divider between the head towards the right, and then the body and the tail towards the left. That kind of typically makes them decide whether they're going to do a Whipple procedure or a distal pancreatectomy. So we thought that's a standard, well-known definition. And so we almost we did decide to use the term of distal from the surgical literature, and then applied it to the term acute pancreatitis, and then came up with this definition of distal acute pancreatitis.
Okay. And what were the actual frequencies that you found?
Yeah, so then we looked back at 2 years worth of patients that presented to our institution. After excluding patients with known causes, we had a sample size of 116 patients. And then the two primary reviewers, based on the discussed definitions, we divided the patients into groups of distal pancreatitis, which made up 16 out of the 100, and then 100 out of the 116 patients had non-distal pancreatitis that had involvement of the head.
Right, so it was uncommon, as you were expecting.
Yes, definitely.
So let's now turn to the non-distal acute pancreatitis group. In those patients, what did you find at follow-up?
Yeah, so Andy, I think a very important point that we need to raise here is saying, so we said unexplained acute pancreatitis, right? The one thing that is unique to our paper is that we did not exclude patients with alcohol and gallstones, which if you read the literature, that if they use the term idiopathic pancreatitis, they would exclude those patients. And the reason why we did not exclude those patients is because we felt that alcohol and gallstones typically involve the pancreatic gland in a generalized or diffuse form, albeit to different degrees. But so that would definitely not be an explanation for the distal group. So that was a long way of saying, we included patients with the non-distal group, any of them that had cancer or prior interventions or known chronic pancreatitis. We excluded those patients. And in that group, of 100 patients, we followed them up, and we actually did not find malignancy in any one of those patients.
Right. So now let's turn to the crux of the study, which is the group with the distal acute pancreatitis, those 16 patients. What did you find in follow-up of them?
Yeah, and that was actually it surprised us at the end because in those 16 patients, more than half of those patients, when we followed them up over time, actually had pancreatic cancer. It would be tough to scientifically say that they had that at the time of the initial scan, but that is certainly our suspicion that might have been the cause for the initial presentation, but obviously we can't be sure.
So when you identify those patients who did have subsequent cancer diagnoses in the distal pancreatitis group, you then went back and did a detailed post hoc assessment of that group, kind of reviewing their records and images for various things. And what did that all turn up?
Yeah, so that was interesting, right? So, the theory or the premise behind this, as we said, is we think that there must be obstruction at the level of the body or tail to the pancreatic duct that then results in the upstream pancreatitis, because it's believed that the stasis in the upstream duct and the premature activation of the enzymes is what sets off the acute pancreatitis. And so then we went back and looked at these patients, and we, in retrospect, wanted to see, are we missing a mass at the level of the body of the pancreas? We didn't see any masses there. We also wanted to see, is the duct upstream dilated? Could we clearly see that? Because we do know that dilation of the main pancreatic duct, typically more than 5 millimeters, is a well-known imaging sign that there might be underlying cancer. And in all 16 patients, we found no mass, and only 1 out of the 16 patients had a mildly dilated duct upstream to the body and tail to 3 millimeters.
And then in terms of how those cancers were eventually diagnosed, kind of what happened between that baseline CT and the later events, kind of what transpired in that interval? Yeah,
so we looked at this retrospectively, and I think the problem is because we're not aware of this entity. So that's why radiologists, when they see this imaging manifestation, including myself, unfortunately in the past, is we would just read it as there's acute pancreatitis confined to the body and the tail of the pancreas, and we wouldn't make any recommendations or any suggestions. So we basically went back and looked at these patients, this group of patients that developed cancer, 9 of them, and they had basically an average of 3 additional scans per patient before basically on the scan, it became clear that there is a mass involving the body of the pancreas. So, and we timed that to when the reading radiologist basically dictated in the report, there is a suspicion for pancreatic cancer. So that was roughly 3 additional scans per patient. And that was in terms of days, I think around 174 days on average, before the diagnosis of cancer was suggested and then subsequently pursued.
Yeah. And then there was one final piece to the study. You had a group of 7 readers who went back and reviewed the cases just for the distal versus non-distal distinction. So what was the purpose of that component?
Yeah. So, whenever you describe a new entity or a new imaging manifestation, as we did in terms of distal pancreatitis, you want to make sure that you define this, the disease or the imaging manifestation, and that is actually, people are able to accurately identify it. So what we did is we took samples of our patients, both of the distal and the non-distal group, and we took readers of variable experience, including people that attend the pancreatic MDCs, attending radiologists, fellow radiologists, even residents down to, I shouldn't say down to, but like second-year residents. And the people were actually amazing at differentiating this imaging manifestation of distal versus non-distal pancreatitis.
Great. Now let's turn to some of the discussion points. So based on your findings, what do you recommend for how radiologists would incorporate this into their practice?
Yeah, as we said initially, unfortunately, this is like the first study that we looked at it, and obviously the numbers are not that high. On the data available, when I would see a patient presenting with acute unexplained distal pancreatitis, I would strongly encourage that EUS to see if they can see a mass and then potentially sampling. And if you don't want to be that aggressive, at least very, very close follow-up to these patients.
Is your group anticipating any additional next steps or further research to explore these findings?
Yes, definitely. So I've got the privilege to be on the Pancreatitis DFP, which is the National Society of Pancreatitis, and we are planning to do a multi-institutional study and to see if these initial results hold up in a larger cohort. And then we could probably formulate more determined management of these patients.
Any additional limitations that are worth mentioning?
Yeah, I mean, as in any study, this was retrospective. It was at a single institution, and we did not look at all at any other predictors of cancers like CA19-9 or a family history of pancreatic cancer. But the reason we did that is because often in the clinical setting, you as a radiologist reading these scans are often not privy to that information, and you have to make a call, in that moment. But certainly, in our future larger multi-center study, we will be looking at additional risk factors.
Great. Any final message for our audience today?
I just hope that not hope, I'm sure the AJR would disseminate this information to more radiologists, because I've looked back in some of the patients that we did not mention this or did not make a recommendation, and I feel terrible about that. But I think the excuse is we did not know about it before, and I really hope that we've got so few chances to detect pancreatic cancer early, and I really do hope we make use of this opportunity if it presented to us.
Dr. Bezuidenhout, I really appreciate your coming here again and sharing your insights with us. Thank you.
Thank you very much for having me, Andy.